السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. Good morning everyone. First of all, I would like to thank the organizing committee for organizing this event. This event is very important event because today we are talking about one of the most common leading cause of end-stage kidney disease and one of the common disease in the world. And as there is a huge progressions in the evidence in medications and agents treating such disease, so it's very worthwhile to specify one and a whole day to talk about the emerging data in treating diabetic kidney disease. So today we will have a full day activity, morning and afternoon, regarding the non-steroidal mineralocorticosteroid receptors antagonists and the diabetic kidney disease. This program is hosted by Department of Nephrology and Kidney Transplantation at Bristol Town Military Medical City, accredited by Saudi Commission for Health Specialties, organized by the Multaqa Al-Khibarat and sponsored by Bayer. This program accredited for 4 CME, and as you can see here, since 1993, diabetic kidney disease start to regarding the evidence of RAS blockade, ACE inhibitor, then after that the ARBs agents in treating diabetic kidney disease. We stay almost like 17 years with this evidence, which is a very worthwhile evidence, giving hands, to slow the progression of diabetic kidney disease. In the era of 2015, the blue one, there's a lot of understanding and a lot of understanding of the concept of the pathogenesis of diabetic kidney disease. That's why SGL2 and GLP-1 agonist, and then since 2020 and 21 and now 22, there is the red one. There is emerging data regarding the selective non-steroidal mineralocorticosteroid. So it showed that there is a lot of work have been done in the last 6 years. Today we'll try to touch one of the most important era emerging and coming up to give a promising future for treating diabetic kidney disease. So I'm honored to be a part of this program, and I'm honored to have my colleagues here, scientific committee and speakers. Dr. Khalid Al-Ma'tham, he's a consultant internal medicine and nephrologist from Renal Transplantation Nephrology Department in King Fahad Medical City in Riyadh. Dr. Hussein Badawi, consultant internal medicine endocrinologist and metabolism. He's a chairman of metabolic unit at the Maya Clinic Medical City in Jeddah. And Dr. Noura Al-Mutairi, she's a consultant pharmaceuticals care and senior clinical pharmacist in area of nephrologist in King Saud Medical City in Riyadh. So we have like a different specialties looking, to this emerging data from different view. Our program today very rich, and we are trying to look for this agent from different view to have more knowledge and more awareness. I know this drug will be in the markets within maybe 2 weeks or 1 month as far. So we are giving one session about the introduction into the diabetic kidney disease and the burden of that disease. Then we will look for the mineralocorticosteroid receptors antagonists from the pharmacokinetic and pharmacodynamic point of view. We will have a talk inciting, on phase 3 efficacy profile, the cardiorenal endpoint. Then in the afternoon, we'll have the same inciting the safety profile from the phase 3. Then we will have, trying to build all together the best candidate and the best time to initiate those agents. It's very excellent, to know as family medicine physician or internist or nephrologist or even endocrinologist to know what is the best candidate to target. Then we will have a case presentation trying to put all what have been discussed together. Then we will wrap up with some take-home messages at the end of the program. So without any delay, I'll turn the mic to my colleague, Dr. Khalid Al-Ma'tham. He's the chairman for the first sessions. And Dr. Khalid Al-Ma'tham, well known for all of us. He's a consultant nephrologist at King Fahad Medical City. He's associate executive director of academic health studies at Riyadh Second Health Cluster Ministry of Health. He's associate clinical professor at Al Faisal University. He completed his fellowship of glomerulonephritis and pregnancy nephrology related disease on 2014 from Toronto, Canada. He has several research publications in the field of nephrology and very prestigious articles. So the mic is yours, Dr. Khalid.
Thank you so much, Dr. Sultan, for your kind introduction. And it's my pleasure to be here with you today. I would like to thank the organizing committee for their invitation. It's my pleasure to introduce our first speaker, Dr. Hussein Al-Badawi. He's a consultant in endocrinology, diabetes, and metabolism. And he is the director of the diabetes program and chair of the metabolic unit at my clinic, International Center in Jeddah, Saudi Arabia. Dr. Hussein has graduated from King Abdulaziz University, completed a clinical and translational fellowship in endocrinology in Michigan, USA, focusing on white and brown adipose tissue. He is a clinical assistant professor of medicine at Wayne State University and American board certified in obesity medicine. Dr. Hussein leads the scientific Saudi group of study of obesity, and he has participated as a national principal investigator in several real-world evidence studies on anti-diabetic medication. Dr. Hussein is going to give us an introduction about the diabetic kidney disease. Dr. Hussein, the mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, my dear colleagues. It is a great pleasure and honor to be amongst the experts in the field of nephrology and diabetic kidney disease in specific. Again, we complete each other as internists, family physicians, in trying to prevent the burden of kidney disease. I will show you in a few minutes. And the title, as you can see, is CKD in type 2 diabetes. So our collective goal is to help our patients with type 2 diabetes live longer, happier, and healthier lives. So, as a question, we will say that globally, the International Diabetes Federation has estimated that there are 463 million adults with diabetes in 2019. That comprises almost 9-10% of the population. Now, if you calculate the type 2 diabetics amongst them, it is usually around 1% of them, so almost 416 million. Now, we know that type 2 diabetes eventually will have some element of chronic kidney disease that ensues, and that is estimated to be 2 out of 5 individuals with type 2 diabetes, leaving us with an estimated 160 million adults living with CKD in type 2 diabetes. That is a huge number, and it is a huge burden on the healthcare system, especially in a country like us, which has a very high prevalence of type 2 diabetes. We estimate that the diabetes population is around 18% in Saudi Arabia. Now, if we were to talk about how we can screen or look for CKD, we will say that it is important for it. Because if I have a patient who is diagnosed with type 2 diabetes, as soon as I diagnose him or her, the standardized 10-year cumulative incidence of cardiovascular mortality is double the risk. So if the general population is 3%, 6% if you have diabetes. Now, if I have someone who is not diabetic but has CKD, chronic kidney disease, that relative risk is actually even tripled. It is 9.9%. Now, if I combine type 2 diabetes and CKD, I will have a 6-fold higher risk of cardiovascular mortality. So this is just to say that a type 2 diabetic with CKD is considered a very high risk individual. All right. So here I can show you that we diagnose chronic kidney disease based on two parameters, either an increase in the urine albumin creatinine ratio on your left, and once you hit 30 milligrams per gram, that is where we define the increased albuminuria. And as you increase in albuminuria on the x-axis, you can appreciate that there's a higher risk of cardiovascular events. The same applies to the decline in GFR. So the second way of detecting CKD is on your right side, where you can see as time goes by, and if we move to your left, so if we say that the normal individual has a GFR that is between 90 and 120, as you move to the left and you decline and decrease in the estimated GFR, you actually see that there's an increase in the cardiovascular mortality. And that is why it is important to detect the CKD in a patient with type 2 diabetes. So we also have seen statistically that there is a shortened life expectancy. Now, we all believe that Allah has already written the time frame for every individual on this earth. But when we look at statistics on paper from all of the years that passed, we see that someone who has diabetes can have a reduced life expectancy by almost 10 years. But if that diabetic develops CKD, then we expect there's probably 14 to 16 years lost of health. And that is why we want to do anything to prevent that progression of disease and reduce the risk of mortality. Now, I'm just moving the slide here. You can see that the natural progression of a patient who is with normal albuminuria and just was diagnosed with diabetes, you may not see any abnormalities in the kidney. But as you move to your right, you can see in the light blue line, we have progressive albuminuria that will develop. And this albuminuria increase actually precedes the decline in the GFR. And therefore, detecting this early on can help us intervene early. And this is where we need to put more efforts in educational activities and awareness campaigns to physicians, because in this study you can see globally type 2 diabetics are not being screened enough. The recommendations from guidelines, whether it is from diabetes, cardiology, nephrology, all recommend that at least annually you should check a urine albumin creatinine ratio and estimated GFR for type 2 diabetics. Why? Because we know CKD will develop. So you can see in the bottom, these are different studies from France, only 29% for urine albumin creatinine ratio, 49% in the US, only 57%. So no one got to 100%. And we are not far from that. That is why we need to start screening more aggressively. So to diagnose CKD, as we said, it is a silent disease. It is asymptomatic. That's why it requires these two laboratory investigations: an estimated GFR, which is calculated based on your creatinine. So you need a serum creatinine, a serum sample, and you need a urine sample to detect the albuminuria, which is a marker of kidney damage. So the clinical diagnosis of chronic kidney disease is defined as an estimated GFR that is below 60 mils per minute, or as a urine albumin creatinine ratio that is above 30 milligrams per gram, which persists over 3 months. Because sometimes you can have a slightly elevated urine albumin creatinine ratio that resolves, and this is due to either antibiotics or nonsteroidal anti-inflammatory drugs, which is a transient thing. What we are talking about is persistent albuminuria. Now, if we want to contribute to our patients from now on, everyone who is watching here should act as a messenger in their facility to try to implement a policy to have annual screening for type 2 diabetics at least yearly. And for those who develop proteinuria or a decline in GFR, it should be at least twice a year. Now, moving on to our next slide, we can see that the way we classify CKD can be based on these two parameters. As you go low from above, there's grade 1 where GFR is above 90, all the way down to grade 5 kidney failure where the GFR is below 15. As progressive worsening. Now, along with that, there is a progressive increase in the risk of cardiovascular disease. The same also applies if you move in grade 3A, for example, where the GFR is between 45 and 59. You can see that the first column has an albuminuria that's between 0 to 29. And then the second column, which is A2, this is the degree of albuminuria. So progressive albuminuria moves to the right. As you have increasing albuminuria, you also have increasing risk. So the highest risk individuals are those with the lowest GFR and the highest amount of urinary albuminuria. That is why we need to educate our patients when we see them progressing in this state. Now, there's a lot that we can do, as we said, as messengers. One is patient-related. We educate the patient. Now, there's a gap in knowledge, which is why we are all here today to try to share this knowledge and appreciate the degree of importance of this. The healthcare systems still need some additional support. Now, some of the things that are happening now in the field of digitalization is having electronic medical records, which can flag a patient whenever we see a decline in GFR or albuminuria. It should alert the physician that, you know what, this is a patient now with CKD. We should have better clinical pathways. Now, let's talk about the pathophysiology of CKD. Now, we know that the drivers of CKD are not just hyperglycemia and hypertension. We have known for many years that the hemodynamic instability, especially with elevated blood pressure, this continuously will lead to interglomerular pressure increase and damage. Along with that, the hyperglycemia and the reactive oxygen species that come along with it will lead to damage of the tubulointerstitial inflammation and glomerular sclerosis. But there's a third element that we have known about, which is the inflammatory burden and the fibrosis that takes place because of the chronic inflammation. All of this will lead to what we can see to the right, the mesangial expansion, the glomerular hypertrophy, and ultimately kidney fibrosis. Now, we have medications to address the hemodynamic instability, which is antihypertensive, namely the class of the RAS blockers or the renin-angiotensin system. One of the early studies in 2001, which was losartan, in the renal study to your left, you can see that compared to placebo, we were able to reduce the risk of kidney progression or kidney disease progression by around 16%. And this comprises doubling the serum creatinine ratio, the kidney failure or all-cause death. And these were patients who had albuminuria. So it became a standard of therapy to use ARBs or ACE inhibitors in order to delay the progression of CKD. Now, fast forward 13 years later, which is in the past 2 years, we have found that the SGLT2 inhibitors, which are anti-hyperglycemic agents, specifically dapagliflozin, empagliflozin, canagliflozin, the DAPA-CKD was a key trial that showed that you can actually reduce that residual risk that we have known. These are patients who have CKD in type 2 diabetes who already are on RAS blockers, and despite that, we were able to reduce the progression of kidney outcomes, which are namely the sustained reduction of GFR, end-stage kidney disease, or death from renal causes or cardiovascular causes. So we are blessed to have two modalities of therapy, which should be the standard of care for patients with CKD. Now, addressing the third element will come after we have seen we have tried to look at other agents. So one of the other agents we tried to look for was the GLP-1 receptor agonist, other anti-diabetic drugs, but they showed a very small improvement, whether it was regarding the improvement of albuminuria. In this study, this is the LEADER trial, which is a cardiovascular outcome for liraglutide, a daily injection. And it showed in the subgroup analysis of the CKD patients that when you use liraglutide in the green column, you have a better cardiovascular outcome, as well as potentially a better kidney outcome to your right by almost 23% or 37% in patients who have some element of CKD. Now, the future was looking into other modalities, but I will stop here as this will be discussed by the following speaker. So in summary, the burden of cardiovascular disease is substantially high in patients with CKD and type 2 diabetes. Despite existing treatments, we still have a residual risk. There's a new focus now on CKD, detecting it and managing it based on many guidelines. And screening for early CKD using EGFR new ACR is underutilized. Therefore, we should all start using it in our institutions. I thank you for your attention. Looking forward to the discussion.
دكتور خالد الآن دكتور خالد.
Section. Yes. Yes, thank you, Dr. Hussein, for your nice introduction about the diabetic kidney disease and shedding the light about the natural history and the development over the last few years. And I would like now to introduce our second speaker, Dr. Noura. Dr. Noura, she's going to talk about the mineralocorticoid receptor antagonist pharmacodynamic and pharmacokinetic. But if you allow me, I have a very long CV for Dr. Noura, and I will try to give a summary about her, mashallah, very long CV to give and just a short introduction about her. So Dr. Noura, she is a senior clinical pharmacist at King Saud Medical City. She graduated from King Saud University with a Bachelor of Pharmacotherapy at 2002, and she achieved her diploma afterwards. Then Dr. Noura, she completed her Master of Pharmacotherapy at 2000, sorry. She completed her master degree in clinical pharmacy in 2013 from King Saud University. Then she achieved her Saudi board in nephrology pharmacotherapy in 2018. Dr. Noura, she has worked as a clinical pharmacist in the field of ICU, internal medicine, and she was working since 2018 in as the field of nephrology clinical pharmacist. She took multiple positions, and most recent one, she is the director of postgraduate clinical pharmacy residency program since 2018 till now. Also, she has multiple prestigious publications in the field of the glycemic control and nephrology. I will give now the mic to Dr. Noura to give us the light about the pharmacodynamics and pharmacokinetics of mineralocorticoid receptor antagonist. تفضل دكتور نورا.
Thank you, Dr. Khaled, and many thanks to the organizing committee of having me. Okay. Okay, I'm sorry for the delay. We will start. I will talk today about the pharmacokinetic and pharmacodynamics. The objective of this presentation, first I will evaluate the role of mineralocorticoid receptors in the kidney and heart disease. Then we'll try to start to understand the new medication, Fineron, and then we'll discuss the pharmacokinetic and pharmacodynamic, and we'll conclude of how to determine to adjust our practice. So, as you know, well, chronic kidney disease is one of the serious of type 2 diabetes, and we have many medications that working to block or to work to decrease the progression of CKD in these patients. For example, in the hemodynamic, which lead to elevated blood pressure, we have ACE and ARB, thiazide-like diuretic, and dihydropyridine CCB, as well as SGLT2 inhibitors. And in the metabolic side, which will lead to hyperglycemia and other complications, we have the relatively new medications, which are SGLT2 inhibitors and GLP-1 agonists. Also, the old medication, which is metformin and the other anti-hyperglycemic agent. But in the side of inflammation and fibrosis, we don't have really medications that work and block this part to delay the progression of CKD in type 2 diabetes. So overactivation of mineralocorticoid receptors will cause kidney and cardiovascular damage through inflammation and fibrosis to many vital organs. In the kidney, it will cause glomerular damage, which will lead to proteinuria, and also it will cause tubular injury and reduce adrenal blood flow, which will lead at the end of kidney injury. In the vascular, it will lead to vascular remodeling and endothelial dysfunction, and it will lead to also increase the vascular stiffness, which will cause hypertension. In the heart, it will lead to myocardial hypertrophy, ventricular remodeling, and fibrosis. It will also lead to reduce coronary blood flow, and it will lead to ischemia and infarction, which also lead to myocardial damage. Let us now go to the pharmacological part of the new medication, which is Fineron. It is a nonsteroidal mineralocorticoid receptor antagonist, which work by decreased inflammation and fibrosis through receptor blocking. So mineralocorticoid receptors are normally activated by two hormones, cortisol and aldosterone. When activated, there will be a gene transcription initiation, and then overactivation of this receptor lead to inflammation and fibrosis. In the kidney, it will lead to CKD development and progression. As you can see in this slide, aldosterone has many serious effect and harmful effect on the kidney and the heart, as you can see in this slide. So by blocking these receptors, we will decrease the inflammation and fibrosis, as we said, but because of it is high selective, Fineron is less side effect, which is the hyperkalemia and gynecomastia compared to spironolactone. This slide just to show you visually how aldosterone will block the receptors and the consequence of the harmful effect. Now let us move to the pharmacodynamic and pharmacokinetic. Phenylalanine goes to or undergo the first pass metabolism. That's why its bioavailability is only 45%. Also, 90% of it is carried by the enzyme CYP3A4. This will lead to a lot of drug interactions, as we will discuss at the end of this lecture. The excretion mainly in the urine and only 20% through feces. Also, it is highly protein bound and its half-life is 2 to 3 hours. The absorption is almost complete. It's almost completely after the ingestion of the tablet, and the time peak will range from half an hour to almost 1.5 hours after taking the tablet in the fasting state. The effect of the food, the high fat content food and the high caloric food will increase the exposure and the concentration of phenylalanine, but this is clinically non-relevant as the patient can take the tablet with or without food. Also, the tablet can be crushed and taken with water or apple juice. The volume distribution is small, it's just 52.6 liters, and it's bind to human albumin around 92%. This slide just to show you or to compare the phenylalanine with the already existing other member in this class, which are spironolactone and eplerenone. As you can see, phenylalanine is highly selective to the receptors, and it is equally distributed between kidney and the heart, unlike spironolactone and eplerenone, which they are more in the kidney. Also, you can see phenylalanine has less side effects in terms of hyperkalemia and has minimal effect on the blood pressure. And has a greater benefit on the cardiorenal, and also it decreases all cause of death. So with all these differences, this will lead to different indication of the two members. Non-steroidal mineralocorticoids antagonist phenylalanine is indicated for CKD associated with type 2 diabetes, while spironolactone is indicated for HFrEF and hypertension. This slide shows you the approved indication of non-steroidal mineralocorticoid receptor antagonist phenylalanine. It's indicated to decrease the risk of sustained GFR decline and end-stage renal disease, also the cardiovascular death, non-fatal MI, and hospitalization for heart failure in adult patients with a chronic kidney disease associated with type 2 diabetes. Also, it is indicated for the treatment of chronic kidney disease stage 3 and 4 with albuminuria in patients with type 2 diabetes. The contraindication are in adrenal insufficiency and the use with strong cytochrome P3A4 inhibitors. Adverse effect mainly hyperkalemia and not much that of hypotension or hyponatremia. And in the initiation, you suspect a decrease in GFR in the first 4 weeks, but then the GFR will be stabilized. Risk factors for hyperkalemia: if the patient has high baseline potassium, or if he's taking other medication that raises potassium, or if he's diabetic or have renal impairment or proteinuria. The formulation, we have 10 milligram tablet and 20 milligram tablet, and dosing is based on kidney function and potassium level. The dosing process is interesting and it will take 5 steps. First, you should obtain the GFR and potassium for your patient, and then you decide your initial doses based on GFR. After 4 weeks, you will evaluate again and you will repeat the lab. Then you will determine your maintenance dose on potassium and GFR. So in the initial dose, you will decide to give the patient 20 milligram or 10 milligram based on his GFR. But if the GFR is less than 25 ml per minute, the use is not recommended. This is the potassium level to adjust your maintenance dose. So if you have the potassium level more than 4.8 milliequivalent per liter, and you start with a 10 milligram, you will increase the dose to 20 milligram. And if you have the 20 milligram, you'll continue the dose. But if the potassium is more than 5.5 milligram per liter, then you should hold the dose, wait until potassium be less than 5, and then you will start again at 10 milligram dose. For the hepatic impairment, you will not worry if the patient have mild or moderate hepatic impairment, but it is contraindicated if the patient have severe hepatic impairment. There is no data for the use in pediatric population, and the elderly, there is no specific dose adjustment. For the body weight, underweight or overweight, there is also no dose adjustment is necessary in these populations. There will be cautions in certain medication, as will we discuss later. For the female of the childbearing potential, they should take effective contraceptive while taking Ferinon. For the pregnant lady and breastfeeding ladies, the use is not recommended. For the drug interactions, strong CYP3A4 inhibitors, the use is contraindicated, while with the moderate and weak inhibitor, you can use with caution, and the strong and moderate inducer, the use is not recommended. For the grapefruit, you should advise the patient not take the fruit or its juice, because that will lead to increase the concentration of Ferinon and increase its side effect. These are the strong inhibitor of CYP3A4 that is contraindicated with Ferinon. I think the most important one is clarithromycin because it's common in our practice. We can use an alternative azithromycin as there is no drug interactions, but all of these lists are contraindicated with Ferinon. For the strong and moderate inducer, the use is not recommended. Example of these are rifampin and antineuroleptic like carbamazepine, phenytoin, phenobarb, as these will decrease the concentration of Ferinon and will reduce its therapeutic effect. For the moderate inhibitors, like erythromycin and verapamil, you can use them and monitor the potassium level. These are the price from the Saudi FDA. As you can see, the same price for 10 milligram and 20 milligram. So to conclude this presentation, the mechanism of nonsteroidal mineralocorticoid receptor antagonist involved in the pathogenesis of CKD and type 2 diabetes, including metabolic, hemodynamic, inflammatory, and fibrotic process. The mineralocorticoids antagonists can have beneficial effect on CKD and other diabetic complication. It had favorable pharmacokinetic and pharmacodynamic properties, and there is a potential drug-food interaction with grapefruit juice, so we should educate the patient about that. Also has drug interactions, especially with the strong CYP3A inhibitors, and has fewer side effects compared with the older steroidal MRA antagonists, and the potassium level should be monitored and the dose adjusted accordingly. Thank you.
Thank you, Dr. Anora, for this nice overview about the pharmacokinetic and pharmacodynamics. For the question, we'll leave it for the end of the first session. So it's my pleasure to introduce our third speaker for the third lecture, Dr. Sultan Al-Dalbahi. He's a consultant of nephrology and kidney transplantation, and also the director of nephrology and kidney transplantation at Prince Sultan Military Medical City in Riyadh. Dr. Sultan is also has held his medical degree from Jordan University of Science and Technology in 2008. Then he held the Saudi Board in Internal Medicine in 2014. Also, Dr. Dalbahi completed the Canadian Nephrology and Kidney Transplantation Fellowship Training Program from Toronto University and McMaster University, Ontario, in 2017. Also, he has been appointed as a clinical research associate from Harvard University in 2018. Also, Dr. Dalbahi is the chairman of the Scientific Council of Nephrology and Kidney Transplantation at Saudi Commission for Health Specialties. And currently, he has been appointed as the Executive Director of Organ Transplant Committee at General Directorate of Health Services at Ministry of Defense, Saudi Arabia. Also, Dr. Dalbahi has several research publications at high quality and prestigious international journals in area of diabetic kidney disease and dialysis and kidney transplantation. Now, Dr. Sultan, he's going to talk about the insights of phase 3 efficacy profile from the cardiorenal endpoints. Dr. Sultan, the mic is yours.
Okay, thank you, Dr. Khalid, for this great introductions, and I'm really very proud to be a part of this, program. And now I just feel, that Dr. Noura and Dr. Hussein make it easy for me, because now I think the audience have more knowledge and information about what doesn't mean this drug and what doesn't mean this problem. So without any delay, I'll go for my presentation, which will be so no potential conflict of interest actually, and my objective here is I think if you can help me for next. Okay, next. So my objective to understand the progression of MRAs based evidence in treating diabetic kidney disease, and to describe the definitions of the efficacy, because we want to treat everything, but actually the evidence for MRA just to specify for specific outcome from cardiorenal perspective. Then we identify the risk reduction and the hazard ratio reductions data of the cardiorenal outcome of MRA in diabetic kidney disease from the 2 landmark clinical trials. Then after that, we will assess, the cardiorenal reduction of MRA among broad spectrum of CKD patient and type 2 diabetes. Next. So as you can see, from 2015, the scientists and the researcher, they work hardly in 2 landmark trials. One is Fidelio, which looks to the effect of the finerenone on chronic kidney disease outcome in type 2 diabetes. So the main part was looking for the renal outcome. And this is why Prof. Perks and his group, they start from 2015 till 2018, 3 years durations. In the same time, there's another group by Prof. Pitt and his group. They work in the Figaro diabetic kidney disease. They look to the cardiovascular event with the Finerenone, type 2 diabetes, and chronic kidney disease. After that one, which I think it's one of the smart, research projects. People, they put, the different population of diabetic kidney disease and CKD all together, and they pull them in analysis. Then they have the fidelity pooled analysis data, which strengthen the belief we get it from 2015 to 2018. Next. So as you can see, the Fidelio and Figaro, they investigated almost 13,000 patients. I think if you go to the literature, this is one of the most, the largest population they look at. And I think the reason for that one is diabetes and diabetic kidney disease is the most common entity in nephrology and area of the cardiorenal. So they screen them, and they have what we call run-in period. This is very, very important, because if you select the right person, you will have the expected outcome. If you contaminate those with inappropriate patient, you might see some side effect. And this is, we will come on that one. However, the Figaro, it's a cardiac dominant study, and Fidelio, it is a kidney dominant study, but they look up for the effect of the Finerenone to reduce the cardiorenal outcomes. Next. Okay, so Fidelio, they included 5,700 patients, and Figaro, they included almost 7,437. So the fidelity as a total of cumulative, it's 13,000. It's a huge number and huge data to look at it. So next. Yeah. So I'll start with the first one. The first one is the Fidelio. It started in September 2015 and ended in June 2018, published in New England Journal of Medicine, the highest, impact factors journal in medicine. It's if you can look in the authors, they are the most leading persons and scientists, nephrologists in area of diabetic kidney disease and CKD. So next. So basically, it's a phase 3 randomized double-blind placebo-controlled and multi-center trials. It's over 48 countries among the world. So they mixed, people from the East, people from the West, people in the Europe, and some areas here and there. So it's representing the global diabetic kidney disease. So the urine albumin creatinine ratio was a diagnostic for diabetic kidney disease. So they look for 30 to 300 milligram per gram, and the GFR more than 25 or less than 60. And or diabetic retinopathy and with albumin creatinine ratio more than from 300 to 5 gram and GFR more than 25. So the bottom line here is that they are looking to, let's say, the moderate to early severe type of patient. It's a very fantastic designed study, very equal, comparative groups. And age is 65, so it's a good age, to look for like a 15 years back, outcome. Predominantly male. However, there is a few African American. This is one of the maybe limitation of the studies. However, the duration of diabetes was 16 years, which is a good, to look for people who have established risk factor from cardiorenal, and you put the drug, then you look for the outcome. It's a very, very controlled glycemia, because I don't want to have a patient who have poorly controlled, then I'll try, because very known is not treating the hyperglycemia. So I should have a controlled, population of participants from the beginning to have the effect. Then if you go back, we will discuss all of these features when we come to the participations. However, the bottom line, it is a very, very mild to severe CKD, diabetic kidney disease, and it's a very comparable, well-controlled glycemia and hemodynamics. Next. So it was 13 patients enrolled or recruited in the study. After the screening, they end up with 5,700, which is expected, about like discharging removing some of them or excluding some of them or some side effect or whatever. Those patients should be on RAS system for at least 1 to 4 months. Why it's very important? Because I don't want to give a phenylenone who wouldn't have a lot on hemodynamic, and in a patient who have hypertensions or unstable RAS system, and then I try to look for that one. So to be honest with the drug, I should we have like patient who is stable from glycemia and stable from hemodynamic. And there is a 17 years evidence of benefit of using ARBs in all those patients. So ethically, we shouldn't remove a drug who have evidence-based to treat something cardiorenal. So it should be there. That's why those patients kept on those agents. They randomize them nicely, double blind. So the principal, they don't know the patient they don't know the principal, and the drug is very anonymous. So it's a very, very double blind. They use the phenylenone 10 milligram and 20 milligram, like Dr. Nora said, and the GFR was the dose adjusted based on this GFR. They look for 2.6 years. This is very important. It's not a short and it's not a long. It's not a short to be like a premature effect, and it's not a long to have more side effects. So it's very, very excellent period to look for cardiovasculars. Next. So they exclude, if you can see in the red side, they exclude unstable cardiovascular patients, advanced heart failure, uncontrolled hypertension, uncontrolled glycemia, and patient with other kidney disease. So if you look to the heat map here, most of the patient, as I said, in the area of moderate to severe area. So almost 80% of the patient, they have proteinuria and they have a GFR approaching 30 to 44. So it's a good and one of the reasons behind that, honestly, this is the common patient we saw in our clinic. I think till we improve our referral system and connecting the patient to the nephrology, we will just keep seeing the same patient. We want to see those patients, but actually they are lagging in the system between general practitioners, non-nephrology services, and nephrology. And I think this is need a lot of system improvement to get it up. Next. So, as I said, all the patients have a 44 average or mean GFR, which is good, to see the effect. And proteinuria almost an 800, which is good. And 99% of the patient are RAS blockade. So it's a well-controlled hemodynamic and well-controlled metabolic and glycemia. And the adherence in that study is 92. This is very excellent to trust the outcome of those studies. Next. So what they assess, they look for the composite renal as a primary, which is kidney failure, sustained, drop 40% of the GFR from the baseline of renal death. And they define it here, at least for 4 weeks to have a drop in the GFR 40% in 2 occasions documented. Death for the renal cause, hyperkalemia, volume overload, or something related to the kidney. And the renal failure is requiring, end stage with GFR less than 15, and starting the dialysis over the 90 days from in the study. So they confirm it in two occasions in over 4 weeks. Next. So the secondary outcome is the cardiovascular, non-fatal MI, non-fatal stroke, and hospitalization for heart failure. And they assess it from the time of initiation to the event, and they just analyze it. Then, there's another secondary, which is they look for hospitalization from any cause, death from any cause, and change of the proteinuria, which is something good to look at it, as a nephrologist, to see how much there are reductions in proteinuria. They look as well, in decrease at least 57% in the GFR from the baseline, which is equal to the doubling of the creatinine. And all of these events should be confirmed in a 4 weeks interval. Next. So what they have as a primary, if you can see the blue line here, it's very, very importantly reduce the risk of having a renal risk. So they reduce the end-stage kidney disease, they reduce the 40% reduction in GFR, and they reduce the death from kidney disease by almost 16%, sorry, 18%. So there is 18% additional to what we have from the ACM inhibitor and ARBs. And the beauty here, it's very started. You can see the blue side start to deviate and to separate from the red area and keep sustaining. If we wait for another 5 years, you might see this 18-30%. So this is very, very important, and you can see it's almost the same in the drop of the GFR. Next. This is for the heart, kidney failure requiring dialysis. It's almost by 13% reductions. Next. The cardiovascular, in those patients, it was reduced by 14%. So if you can come, here in the secondary composite outcome, you can see all of the composite, it reduced by almost hazard ratio 0.86, which is almost like 14% reductions. And the B value was very significant, 0.03, very significant. Next. So proteinuria, if you are one of those nephrologists who is putting a proteinuria as outcome every now and then, like in GN or other diseases, yes, you can use it as a surrogate. So you can see over 4 months from starting, you will see almost a great reductions in the proteinuria. So it's almost like a 50% reductions of proteinuria. And the beauty, it's keep persistent almost among the 36 days. So there is no risk of bounding or rebounding or partial remissions or whatever. So it's very effective in reducing that part. And this is increasing, like now the urge for the researcher to look for the IgA, for the non-diabetic kidney disease, proteinuric patient, CKD, to look for optimizing the care by adding finerenone. Next. This is kidney study, Fidelio. Now we will shift to the FIGARO, which is a cardiovascular study. Started in the same time, 2015, through October 2018 end, and it's published in the same journal. I think it's like, when we publish one study, then the journal will be very interested to publish another study in connections to just like filling the gap and continuation of the knowledge. Next. So they screened 19,048 countries. They found 740 with age of more than 18 or equal and type 2 diabetes, RAS blockade, and they have a CKD by proteinuria or CKD by drop in the GFR. And it should be a 2-set in interval to confirm that part. You can see in the table, they are very equal and very similar design to the Fidelio. You can see the age is 64, and you can see more male, less African American. However, the glycemic control was very controlled and hemodynamic was very controlled, and you can see those patients both in standard of care in terms of RAS blockade and glucose lowering therapies. Next. So as I said, it go through the same run-in period and screening, and they follow up the patient 3-4 years, follow up as a cardiovascular dominant outcome. Next. As we said, most of the patient included in that study, like 60%, they have stage 1 to stage 2. So this is the difference between the FIGARO and Fidelio, because FIGARO, we know when we progress to like stage 3 or less than 45, the cardiovascular risk is already sometimes established or even high. So there is nothing to prevent. I think one of the beauty in that study, 62% of the patient has GFR almost 60 or more. And this is very excellent to look at it. The median urine albumin creatinine ratio was 300.8. Why? Because we are not looking for reductions of the proteinuria and renal outcome. It's a mainly cardiovascular. That's why we are taking, we are learning from Fidelio, then we are selecting a patient, because the effect for the renal outcome, it's already established by Fidelio. And this study was established to, take more fit patient to predict and prevent the cardiovascular outcome. So I think this is one of the differences between both studies. Next. You can see like the primary outcome with the cardiovascular morbidity and mortality. It's almost the same definitions of those in Fidelio. Next. And renal outcome, it's almost the same. Next. Yeah, so the renal outcome is almost the same, 40% reductions in the stage requiring dialysis over the 90 days of initiations, or patient went to the kidney transplantation. So this is like, the same definitions of the renal outcome, but it's secondary. Next. So cardiovascular, it was reduced by 13. It was there 14% in Fidelio. When we take more, mild to moderate patient, we found it's almost the same risk reductions. Next. When we come to all, kind of cardiovascular, it's almost the same, and showing the 13 as a composite, the 13 risk reductions. There is no much, differences like in hospitalizations, for example, because we are using a mild to moderate patient, so it's almost comparable to the placebo. But the composite, non-fatal MI, non-fatal stroke, and heart failure, or admissions for heart failure, for example, it's 13% reduced in compared to the placebo. Next. This is just showing that, there is a huge in all subcategories of outcome, it's in favor of using the phenylalanine compared to the placebo. And it's almost ranging from 16 to 18% risk reductions from cardiovascular and renal survival. Next. Okay, so as a summarizing for this two trials, in Fidelio, which is the initial one, was moderate to severe CKD, type 2 diabetes. It showed reductions in the chronic kidney disease progression 18%, which is significant statistically, and reduced cardiovascular mortality and morbidity by 14%. If you take more milder patients, early stages, you can see the same effect. It's 13 equal to 14 cardiovascular mortality risk reductions, and you can see 13 and 18 risk reductions, chronic kidney disease progressions. Next. Okay, so Fidelity, it's like a pooled analysis. It's not a real research project, just analyzing and taking subcategories and making like Cox regressions, logistic regressions of the variables, and looking to the differences between the two studies. It was in the same time. They're just like doing interim analysis, then interim analysis, till they end up on the same time of publishing the Figaro and Fidelio. Next. Okay, so we showed when we bought like 13,000, then another 13,000, then 19,000, we see like 33,000 patients from 48 countries screened, and 13,000 were randomized in those two studies. Then different stages, stage 1, stage 2, stage 3, and stage 4. At least more than 25 ml GFR. And they randomize them according to the protocol mentioned by Dr. Noura, and they look for the cardiovascular composite and renal outcome composite. They look for the 57 reductions of the GFR from initiation of those medications. Next. Then they found, that if you look for those studies, they are using very, in that analysis, they took the different type of the albuminuria or albuminuria. So most of the patients, they have albuminuria. They took them from the Fidelio because I know there is no much in the Figaro. So they put all together. And most of the patient 40, they have a GFR more than 60. So it turns from this study that we are looking now to a proteinuric CKD patient, not a patient with low GFR. And what is the outcome have been seen in that study? Next. You can see the cardiovascular in those type of the proteinuric CKD, 14%, and the heart failure risk reduction, 22%, and the renal, it's 23%, and the dialysis reduced by 20%. Why the outcome improved? Because we select and we learn from this pooled analysis the appropriate candidate for those drugs. And I will come in the afternoon presentation, who's the best candidate and what is the best time to initiate finerenone. Next. So is it a matter, this is a lot of questions coming down, is there any contribution to SGLT2? I know in the study, which is thankfully, which is good, just 6.7% of this population have SGLT2. So I can swear that what we have from this, risk reductions shown in Figaro, Fidelio, and Fidelity, it's not contributed to the SGLT2. I know SGLT2 is very excellent drug, showed very excellent outcome, but in those kind of population, finerenone has a role and leading the rules in addition to the RAS blockade. So you can see here that without SGLT2, there is a 32% risk reductions, especially in proteinuria. If you add SGLT2 in this minority, it's like if you rising 37%. However, it's like different, 12,800. There is a different, two arms in that study. But definitely what have been reduced is contributed to the finerenone. Next. And this is just like sub-analysis about the cardiorenal, the cardiovascular, the renal, the heart failure, and the stability of the GFR, all toward finerenone, and it's very equal to using SGLT2 or not using the SGLT2. Next. So as a conclusions, in a patient with CKD, type 2 diabetes, treatment with mineralocorticoid agents result in lowering the cardiovascular CKD progressions and cardiovascular endpoint than placebo. Among type 2 patients, stage 2 to 4 CKD with moderate elevated albuminuria, or type 1 and 2, like in Figaro, with severe elevated albuminuria, MRA therapy improve the cardiovascular outcome as compared to the placebo. Pooled individual level analysis from Fidelio and Figaro where there were reductions in both cardiovascular event and kidney failure outcome with the mineralocorticoid agents, because 40% of the patient had estimated GFR more than 60, they were identified slowly based on the albuminuria. So it comes, like it can be labeled as anti-proteinuric agent because it's treating the fibrosis in the kidney, not like the hemodynamic. I think the most important bottom lines here, screening for albuminuria to identify at-risk patient among type 2 diabetes facilitate the reduction of both cardiovascular and kidney disease burden. At this stage, I'll thank you, Dr. Khalid, and thank you for the audience, and the mic is yours, Dr. Khalid.
Thank you, Dr. Sultan, for this really nice overview about the efficacy and the showing the data from the main important clinical trials about the new MRA. I think now we finished all the lectures for the first sessions, and it's the time for the discussion and the questions. I can start with one question to Dr. Hussein. So, Dr. Hussein, from your experience, do you think that the utilization or detection of the albuminuria, you think it's underutilized here in our population, or it is it's appropriate in our practice?
Thank you for the question. Of course, we don't have like strong data that speaks about our whole population, but I can tell you that individual centers, for example, when we initially started the diabetes program, we wanted to see how well we were doing in performing and conducting the annual screening programs. And unfortunately, in a place where patients have access and physicians are aware of the required screening, we would say that almost half of the patients with diabetes were not getting annual screening, which is the bare minimum. So I believe truly it is something that we should work on.
Thank you, Dr. Hussein. Also, I have a question to Dr. Noura. From your experience, most of the our diabetic patient, also the patient who have CKD, they have polypharmacy. And do you think from the commonly used medication, is there any medication that can have an interaction? I know that you mentioned the CYP inhibitors, but these mainly like antibiotics and others. But is there any concern from the RAS inhibitors, from the SGL2s, other medication? Is there any specific medication that we should have a red flag about when we use it with the MRA or the new medication?
Yes, thank you, Dr. Khalid, for the questions. Polypharmacy defined if the patient has 3 medication or more, which is the case in our patient CKD and diabetic patient. They always have multiple medications, and I think you experienced this in your clinic. They came with different brand for the same medication. They for example, have 2 RAS, but from different brand, and they are taking together. The patient did not know. So this is the role of the pharmacist to identify this and to prevent the duplication of the medication. For the MR antagonist, we care about the hyperkalemia with the RAS. So the patient should be educated to follow up with his physician regarding the GFR and the potassium level. Also, the other medications, because of its polypharmacy, it's most likely to have some drug interactions with the antibiotic, as I mentioned in the slides, especially clarithromycin with MR antagonist. So yes, we should pay attention to these drug interactions.
Okay, thank you, Dr. Anna. I'm just looking at the question from our colleagues in the audience. So we have a question. The first one is I think it's written, what's the contact between obesity and CKD? I think maybe the relation between obesity and CKD. Maybe Dr. Hussein.
Of course, there is, let's say, a direct relationship or a direct association that we have seen, and there is an indirect relationship. So one thing that we should keep in mind is that obesity as an association has been associated with more than 62 chronic diseases, which means that in a patient with obesity, you are more likely to find it. One of them is CKD. There is also this fact that we spoke about, the inflammatory burden. So obesity is a pro-inflammatory state. Increased adiposity, especially visceral adiposity, leads to more cytokines productions or harmful cytokines, which leads to progression of different diseases. One of them is CKD. What is now being entertained is an entity called obesity-associated kidney disease. So, metabolically healthy individual yet has an element of kidney damage, and this is still being, let's say, studied and trying to look into from a mechanistic point of view. So. That is what we know as far as now.
Okay, thank you, Dr. Hussein. I have a question to Dr. Sultan. So, what is the reason that diabetes risk cause kidney problem? It's mainly, I think, it's about the mechanism.
Well, yeah, الصوت واضح؟
إيه تفضل دكتور واضح.
Yes, this is very, very important questions. I mean, we keep, for many years believe that we need, GFR to drop, creatinine to increase, patient to become nephrotic, to have a kidney disease. But I think now all the understanding and the research, actually the transitional research, they start to know that the kidney disease starts earlier than what we expect. And one of the most important effects, not structural effect, is the dysregulations of the RAS system. When you put a lot of burden and you make the kidney very burned out. And I think this has started, maybe like 3 years or 5 years from poorly controlled diabetes type 2, or even with controlled diabetes type 2, not on RAS system. So all the studies showed that the diabetic kidney has renal hypertension and has some area of dysregulations of RAS system. And I think this is the key point that, when we predict it by, just putting RAS system and trying to look for the effect on that one. So how does it? This is the first process. Then after that, if keep, not treated or not secured source of kidney, will start the structural damage, which is like hyperfiltrations, increasing the blood to the kidney, which can damage the mesangium. The mesangium can get expanded, the podocyte can get affected, the proteinuria can start in the urine. Then after that, it will be like a very vicious cycle. Then the afferent and efferent arterioles starting to react to that one by, constricting, then the intraglomerular pressure will increase. So this is how the kidney get damaged by. However, all of these will lead to the fibrosis, which is targeted now by the finerenone.
Thank you, Dr. Sultan. We have a question. Maybe it's not. I will keep it to the end. So there's also a question: does nonsteroidal has an unfavorable effect on eGFR? This I'm going to answer it in the afternoon session. So we'll skip the question now. Is it available in the market now? The medication?
Well, I know about Dr. Noura. She's our eyes in the Saudi FDA. So I know it's approved, but I think it's available in the private and in the governmental.
Yes.
Within 2 weeks, maybe.
This is
I
what
can at
I
least
know so far.
comment that we were able to obtain an order of this medication this month. So, but it's a very low scale, only selected areas. So it's still not widely available, even in commercial pharmacies or commercial clinics.
True. Can we use this medication as a prevention for CKD or cure for CKD? And I think they mean from the question, in non-diabetic patients, if you have CKD, now we see with the SGL2, it's used for CKD slowing progression and treatment. Can we apply the same principle for this medication?
Well, I think this is very excellent questions, and the future will tell us, because when you come to any new drugs, they just prescribe or discover that it's effect in treating some areas. But when we have more patients, more research, more papers, we can see the efficacy in the non-diseased or at-risk type of patient. So far, it's not indicated, because here we are treating pathology, which is the fibrosis, and the at-risk kidney already secured by RAS system and SGL2. Maybe in the futures, because when we come to the FIGARA and Fidelity, the patient with normal proteinuria, which is the main target here, there are few. So I think it's not well designed study to look for preventions, but future will tell us, and it's an open area for research. If people they can get approved to use it for as a prevention.
I think we have a few questions about the practical. So I will leave it for the lectures for the afternoon session, and I'm sure it will be answered at that time. Just one question about is it a drug that you lose it for life, or is it titrated according to response or progress? Also, this I will leave it to the afternoon session. There's one question about the Fidelio and Figaro studies. Are they still ongoing, or they reached a conclusion?
Well, they stopped, and even they stopped earlier than what we expect at the time manners. I think they approved ethically for 5 years, and with interim analysis of 2.5 years, they found the expected effect in the 2.5. So ethically, like in ethical committees, we shouldn't proceed if we get the outcome. So it's already stopped the both studies, and there is another studies now looking for in some areas in those studies. I'll just mention it in my presentation afternoon about the combinations process and specific populations. And
Sure. I think now we reach the end of the morning session. We still have some questions. We can move them to the afternoon session because they are related to some of these topics. So I would like to thank all of our speakers for their nice presentation and lectures and insight about this new education. And I think now we will go for the break for 30 minutes. For the prayer and lunch, and then we'll be back inshallah at 12:30. Is that right, Dr. Sultan? Okay, perfect. So I would like to thank all of our attendees, and we'll go for the break now. And I would like to thank our speakers, and we'll see you in the afternoon session, inshallah.
thank you.
احط تفضل دكتور سلطان.
بالعكس حسين، على الرغم من التحديات وتجربه جديده، بس الارض كانت
اللهم بارك، يعني الحمد لله السياق كان ماشي كويس.
دكتورة نورة اللي أحبها.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Welcome again in this afternoon session and the webinar Non-Steroidal Receptor Antagonist and Diabetic Kidney Disease. Our first speaker will be Dr. Khalid Al-Matham, who is well known in his specialty, and he's introduced earlier by Dr. Sultan. He's consultant internal medicine and kidney transplant in King Fahad Medical City. Welcome, Dr. Khalid.
Thank you, Dr. Nora, for your kind introduction, and it's my pleasure to be part of this rich program. So I'm going to talk about mainly, this is the outline of my presentation, the unique structure of this MRA and comparison with other MRAs. And we'll talk about the trial safety data, and I will have some take-home messages. So I decided to start about this structure and the function of this MRI because it's important to know exactly how does it work. And as you know, the mineralocorticoid receptor agonists, they work mainly on the sodium and the potassium, and this is really important and related to when we talk about the side effect of the medication and also the cortisol. If we see what is the general comparison between the non-steroidal and steroidal MRAs, and I will take an example for the comparison, is spironolactone, which is commonly used here locally in our practice. And I know that the other medication like heparinone and others, but it's not available here. And also Dr. Anura has well described this in her presentation, but I'll just shed highlights about some of the important side effects. One of them is the effect on renal and electrolyte disturbance. And if you compare it, the finerenone or the new medication, it has lower risk if we compare it to the spironolactone. And reason behind that, because this MRI has a unique structure and highly selective, and also of the mode of the binding. In addition to the use of the cofactor for recruitment, it make it more selective and reduce the risk of the electrolytes. The other common side effect that we face with the spironolactone is the gynecomastia, which is sometimes disturbing for the patient. And if we look here at this medication, the risk here is not different than the placebo, so it has lower risk than the standard MRI that we have, and the reason because it's highly selective medication, and spironolactone is low selective medication. Also, for us as nephrologists, also the cardiologist, always when we have any medication, we want to see the risk of hyperkalemia. And the risk of hyperkalemia here is lower in comparison to the standard spironolactone. And as you know, it is commonly used for the patient with heart failure from the Wells trial, and also as resistant hypertension medication. So this is a concern when we want to start this drug, especially if we have the RASI blockade, as mentioned by Dr. Anur, as a risk factor for it. And the reason why it has lower risk of hyperkalemia, some of it's because of the mode of gene expression, the half-life of the medication, and the presence or absence of the active metabolite, which is different from the spironolactone. I'll talk also about the effect on systolic blood pressure effect, and it's moderate in comparison to the spironolactone. And as I mentioned, that's why spironolactone, we can use it as antihypertensive medication, especially for resistant high blood pressure, but it's not the same scenario for finerenone. Here, this is the summary of the trials that was described very well by Dr. Sultan. And I will not talk about the outcomes, but if you see just below at the end that the safety, that both trials it showed that finerenone was generally well tolerated, and the increased incidence of hyperkalemia had a minimal clinical impact, and I will show the details of that in the coming few slides also. Okay. If we look at the overall incidence of the treatment emergent adverse event between the placebo and the intervention group, we can see here, if you look starting from the left side, if there's any adverse event, there's a similarly the adverse event rate was similar between the two groups. If we look at serious adverse event, it was also similar. And if we look at the acute kidney injury, the percentage is around 4%, and the gynecomastia is 0.2%, which is similar between the two groups. Here's from the Figaro study, which is mainly its cardiac study. And here's the safety outcomes table from that trial. And Dr. Sultan described it very well, and I will just focus on the safety outcomes. And here, what they did actually, when they reported the safety outcomes, they divided them about any in three categories, which is nicely done. That if there is any adverse event in general, and they compare between the finerenone and the placebo, and we can see here the overall comparison between the two groups is similar. They looked also at the second thing is the hyperkalemia, and when they looked about the incidence of the hyperkalemia between the two groups, it was similar, but also they looked at if there's a serious side effect, if there's hospitalization due to hyperkalemia, and if this hyperkalemia led to discontinuation of the medication. And we can see from this table from Figaro study, it was similar. Also, they looked at hypokalemia, and then they looked at related adverse event, acute kidney injury. And again, not only just the incidence of the acute kidney injury between the two groups, which was similar, they looked also if this acute kidney injury lead to hospitalization, discontinuation from the trial, and also they looked for general side effect like diarrhea or GI side effect that we commonly see in other trials. Similar thing we can see from the Fidelio, which was mainly renal. Also, they divided this for general. They looked also about investigator-reported hyperkalemia, and it was also similar. There was no higher rate of serious hyperkalemia or leading to hospitalization or death. And all of these, like if there is a difference, it was not clinically significant. Also, here in this study, they looked about other risk factors like pneumonia, diarrhea, like constipation, general side effect, and it has a similar safety profile between the two groups. I want to focus now on this slide about two things. As you know, we're talking about mineralocorticoid receptor antagonist, and we assume in mind, because from our experience, that this is an antihypertensive drug. You can see here on the left side, you can see the change of the systolic blood pressure over time, and you can see the difference between the intervention and the placebo group. It was not significant, and it's only reduced by like the maximum 2.84 millimeter mercury between the placebo and the intervention. So it has a minimal effect, or we can say moderate, but it's not an antihypertensive medication. So we don't have a concern about dropping the blood pressure if it is already well controlled. Also, the other thing which come to our mind, since we are talking about diabetic patient, and so is this a medication that is going to affect the glycemic control, or does it have an effect on the A1C? You can see here there's no difference between the finerenone and the placebo group, so it's not anti-diabetic medication, and it has no control over the glycemia. How about the most important thing for us is the potassium? As a nephrologist, I say it's most important, but it's one among the others. So we can see that the maximum mean difference in the serum potassium between the two groups was only 0.23 micromole per liter at 4 months. So the difference between the two groups, it's not significant, which is just a little bit rise of potassium. And so what is this event? Is not, it's a small number. Does it have any consequences? I'll show in the coming slide that here, if we look at the this graph here, there is a comparison between the finerenone and the placebo, and we can see that if this drug has led to permanent discontinuation, we can see it's only 2.3%, and it was in the placebo group 0.9, so there's no statistically significant difference. Does it lead to hospitalization? Also, the difference is not statistically significant, and there was no reported cases that this drug led to death. So we can see that it does not cause hyperkalemia or significant hyperkalemia, and even for those patients who had the hyperkalemia, it did not have a serious or major clinical impact on those patients. This is from the Fidelio, and I'm focusing about the Fidelio trial because it's mainly renal. We can see here on the right side, the blue color, that the overall treatment adverse event and serious adverse event, they were similar, and this is the summary from that trial. Here in this slide, just from the Fidelio, they used a specific protocol to introduce the drug and to manage the drug titration according to two factors, actually the GFR and also the serum potassium. But I will not describe it or talk about it now because it's going to be, it was partially explained by Dr. Noura and will be explained by Dr. Sultan in the coming lecture, inshallah. There was a lot of questions, and it always come to our mind as a nephrologist or even physician. And this question comes from the previous trials, like the RAS inhibitor. When we initiate the drug, we expect that it will have an effect on the GFR, and this is allowed up to 25%. Same thing came when the SGLT2 were prescribed, that it has some effect on the GFR, and it was again concluded that it was physiological and beneficial effect. It's not harmful. From this trial, we can see here that after the initiation of the finerenone, in the first maybe 4 weeks, there was just a minor drop on the eGFR or the GFR of the patient, almost like 3 ml per minute on those patients. But if we look here on this graph on the right side, we can see that although there was initial physiological drop, it is not significant, and overall it has an excellent preservation of the GFR over the long term. And actually, those patients at the end of the trial, they did better in the terms of the preservation of GFR in comparison to the placebo. So this might answer some of the question that we had in the morning about, does it have an effect? Yes, it has a minimal effect. It's not harmful. It is physiological, and we expect to see it in the initial 4 weeks. But if we compare it to the overall, it is an excellent outcome. How about the Fidelity study, which is the pool trial or the pool analysis of both Figaro and Fidelio? And in this, as we know that they have 13,000 patients, you can see here that, again, this is the same classification for the adverse event, and there was a similar safety profile between both arms, the intervention or the placebo, and there was no any major differences or statistically significant changes between the two arms. Here's just the continuation of that. Also, this is the general side effect, the hyperkalemia, nasopharyngitis. diarrhea, constipation, pneumonia, all of them, they are similar between the two arms, and there was no significant difference between them. Just here is the summary, and this is from the fidelity. And if you can see here that the hyperkalemia was 14%, and it was in the placebo 6.9%. It's not statistically significant, and leading to hospitalization because of hyperkalemia or leading to permanent discontinuation of the drug. There's no difference between the two trials or the two, arms. The risk of hypotension, it was similar. As I said, it has moderate effect. And if there is a risk of hyponatremia, there was no concern about hyponatremia and those patients. So, as I mentioned, the permanent discontinuation of the drug was only 1.7% in comparison to 0.6%. So, overall, from the fidelity, which is the largest pool analysis of the trial, it was a safe drug, and it was not different from the placebo group. So we reviewed the safety profile of the medication from the mainland trials that we saw, and we can say that epinephrine has a comparable safety profile to the placebo. The risk of hyperkalemia is minimal and manageable. And we mean by manageable, if it is there, we have multiple ways we can mitigate this risk, and we can continue to have this benefit of the medication. All the phenylalanine is mineralocorticoid antagonist, but it has no significant effect on blood pressure, and the drop in the GFR initially is minimal, and overall preserve of GFR on long term is significant. With this, I come to conclude my presentation, and thank you.
Thank you, Dr. Khalid, for this informative presentation. Our next speaker is Dr. Sultan Al-Dilbahi. Dr. Sultan is a consultant in internal medicine and nephrology. Also, he is the head of nephrology department in Prince Sultan Military Medical City. Welcome, Dr. Sultan.
Joining this, very exciting program, and as Dr. Khalid said, this is very rich information, multidisciplinary, and all of my colleagues make my slides to be easy. I know from the beginning it's very difficult to find in the literature what is the best time and what is the best patient. Yeah, what is the best time and what is the best patient to start them in those medications. I know it is. I'll try over the coming 15 minutes, to look to the articles from the front view, not the efficacy view and not the safety view, trying to say how much, what is the most common type of patient, CKD patient, and what is the degree of proteinuria, and what is the most optimal effect in those. Then we will take them as the appropriate populations. So next. Okay, so no conflict of interest, and okay, my objective to describe, the screening process for suitable diabetic kidney disease patient. This is not an easy, because I know it is one of the missed area in nephrology. A lot of patients with good, very targetable stages, they are not connected to the nephrology program, and they are lacking in the system, as I said. We should identify what is the diabetic kidney disease patient we want to treat them. Then what is the role of RAS blockade in diabetic kidney disease? And we will try to look for what in the trial they did as inclusion, exclusion, why they select certain populations and why they exclude certain populations. Then after that, I'll try, to know which stage and what is the degree of albuminuria are favorable before MRA's initiation to diabetic kidney disease patient. So this is just like from American Diabetes Associations 2022, when they mentioned that as standard of care, we should screen all type 2 diabetes for some element or evidence of diabetic kidney disease. So they should have anyone, urine albumin creatinine ratio, whatever, 24, or spot urine albumin creatinine ratio in those patients with type 2 diabetes more than 5 years, or type 1 or type 2 in a time of the diagnosis, because we know they have diabetes even years prior to their presentations. Or if the patient have like a proteinuria more than 300 milligram per gram, an estimated GFR from 30 to 60, and they should be screened twice. Actually, if the beginning showed that like this, I think we should repeat it in some interval, at least 4 weeks, to make sure that this is the type 2 diabetes and have some evidence of diabetic kidney disease or CKD. So the first criteria, the best patient who known to have a diabetes for 15 years. I know it's difficult. Some of the patient with some health records, we don't know when diabetes started. But the majority in the trials, they have more than 15 to 16 years known diabetes and known duration of diabetes. So this is the first favorable criteria. The second favorable criteria, those that type 2 diabetes, they should have CKD, either by having albumin creatinine ratio more than 30 milligram, but less than 300 milligram per gram, and estimated GFR from 25 to 60, and the presence of retinopathy in a medical history. Or if you can have all of these, we should have like a persistent high albuminuria, more than 300, and GFR from 25 to less than 75 by using the CKD-EMBI equations. So the second criteria to start this patient, it should be a CKD features. Next, I think I have okay. So criteria 3, those patients should be a RAS blockade. Ethically, they should be a RAS blockade. We cannot omit RAS blockade system, AC inhibitor and ARBs from the medications treating those patients, because we are treating the patient as a whole, not looking for the renal outcome, because there is a lot of benefit from using RAS blockade. And some of those benefit is the cardiovascular. So we should put those patients in that one. And the other reason, I think, to look for effect on the fibrosis, which is the other land of the kidney, which is I think we should secure the other side of the rifle, or the other side of the kidney, which is the outstressed RAS system dysregulations area. So I think we should have like a 1 to 4 month, whatever, at least 4 weeks on tolerable dosage of RAS blockade. AC inhibitor or ARBs, there's no differences between that one. And if you can see the studies, they put it in the run-in, and then after that, they screen the patient, not screening the patient prior using the RAS blockade. And this is a very, very mandatory ethical. Next. Criteria 4, it's next. Yeah, criteria 4, they should be on standard of care for glycemic control. And if you can see in those studies, this is from the Fidelity, the Figaro plus patient who have like stage 1 and 2, and the Fidelio patient who has stage 3 and 4 with different degree of proteinuria. They are in a good glycemic control. Look at the hemoglobin A1C here, 7.7 plus minus 1.4, and this is one of our targets, by the way, in treating type 2 diabetes. And they are, this is very equal between the placebo and between the treated arm. And this is very, very, very mandatory that those patients should be in a good standard of care and good glycemic control. Next. Criteria 5, those patients should be with hemodynamic control. Whatever the measures you do, like, we prefer the RAS blockade, and this is one of the mandatory in the study. So they should be RAS blockade, and they should a good systolic and diastolic blood pressures, reflecting that RAS system already regulated and controlled by using the RAS inhibitors, which is AC inhibitor or ARBs. This is, well, you can look to the blood pressures in the first slide. It's a very, very 133 to 136 as a maximum, and well-controlled patient by using of that one. Next. Okay, they should, sorry, can you go back, sorry? Yeah. They should be hemodynamically controlled and glycemic controlled. So all of these patients have the standard of care for diabetes. So they are using the lower agent therapies. 97.5 patients in intervention arm by using the finerenone. They're already on insulin, majority, or GLP-1, Saxenda or Ozempic, 7.6, and they are in SGLT2 6.7. Whatever the kind of, or metformin, most of the patient are metformin, because the GFR is allowing. But the bottom line here that they should be controlled before we start that one. I know this drug will be in the markets within 2 weeks, and it will be very, very, enhanced. We shouldn't use it for a patient to treat diabetes, to treat CKD. No, we should optimize our patient before adding those medication to expect and see the beauty and the benefit of this patient in really stable patient. Next. Criteria 6 or criterion 6. This patient should be moderate to severe diabetic kidney disease. So GFR with a median like 44 to 60, the earlier is the better, and the late albuminuria 300 to 5 gram. It looks a proteinuric drugs. So if you look to those included in Fidelio or Figaro, they are trying to take above 25 to less than 75. But if you look to the GFR, down here, most of the patient, 40% of the patient above 60. So let's say more than 1/3 of your patient or half of your patient have a very early CKD. This is the opposite way to the proteinuria. So the proteinuria is very late, and it looks like very proteinuric. And this is, I think, proteinuria is reflecting the fibrosis in the kidney. So that means, more proteinuria, more fibrosis. That means the drug can have a place to work and to prevent. Potassium-wise, as Dr. Khalid said, better to be less than 5, the best to be 4.8 as mean or average, but it should be very controlled and in the maximum dosage of RAS inhibitors. Next. Okay, what they exclude from the study? They exclude patients who have kidney disease for non-diabetic kidney disease, like renal artery stenosis, and diagnosed by biopsy or clinical. So we shouldn't use finerenone for those patients. A huge or nephrotic range of proteinuria, massive proteinuria. I know there is a lot of diabetic patients now on RAS system, and SGLT2, and they have more than 5 grams. Don't believe that adding finerenone will help them. There is no evidence to use the finerenone in such nephrotic range of proteinuria. A glycemia control, they exclude any uncontrolled, more than 12, any uncontrolled hypertensions, any uncontrolled heart failure, and any uncontrolled cerebrovascular, like stroke in 30 days. Patient on dialysis not included. Patient transplanted not included, because there is no safety data. However, it will come, when we have more safety in non-transplant, we will try to have, the interest to do it in transplant. Patient with hypersensitivity to such a drug or metabolites, Addison disease patient when they have a risk for hypertension, and liver disease, and active malignancies at least within the first year on active management and pregnancy or breastfeeding patient or patient want to get conceived or pregnant, because what you are doing for the pregnant woman, we ask her to stop RAS system. RAS system is one of the components of the phenomenon efficacy. So we will find a lot of difficulties to take decisions. Better to avoid the pregnancies. At least when we bring the whole things down, then we can think about holding the drug. There is no data or safety on the pregnancy. The future will tell us more about this. Next. Okay, so there's some medications very concerning. Commitment of this therapy with ibuprofen, spironolactone, or any renin or potassium sparing should cannot be discontinued at least for 4 weeks before MRA using. So it should be at least 4 weeks discontinuation. I know there's a lot of metabolites. Adding phenylalanine might accumulate in those metabolites, then side effect might come up, and phenylalanine will behave like non-selective. Concomitant therapy with ACE inhibitor on ARBs cannot be discontinued for the purpose of the study, so this is ethically. As Dr. Anora said, commitment with therapy with potent cytochrome B450 and 3A inhibitors, A4 inhibitors or inducers, all of these medications should be stopped at least 7 days from before initiation of the MRA. Next. Next. Yeah. SGLT2 therapy, never a matter. Using, not using, combining, not combining, the phenylalanine is very, very irrespective and independent to the SGLT2. This is a study as I described in my previous presentations. So the additional effect is very minimum by SGLT2. The majority of the patients, they were not in SGLT2. Next, the big questions now coming in the literature about could we use it? Now the answer to use it without SGLT2, yes, it's safe to be used. Could you use it with SGLT2 in the same time? Next. Next. Yeah, this is a study published in NDT in 2022, last June. Started by the team were involved in Figaro and Fidelio, and they start like 269 patients in phenylalanine plus empagliflozin in the same time, and 269 patients in phenylalanine alone, and 269 patients in empagliflozin alone. So they include like 800, well distributed. It was multi-centers in 13 countries. They use the same and the typical in the Fidelio and Figaro. Patient with CKT 2 to 3, albuminuria more than 300 milligram, less than 5 gram. They exclude type 2, type 1 diabetes to reduce the risk of having like ketoacidosis by SGLT2, and they exclude potassium 4.8 and patient treated with SGLT2 or MRA previously. So they just exclude them and they just start a new type of patient. They look for the kidney in the dual therapy, in the phenylalanine, and in the SGLT2. They wait for 118 days, which is I think very, very reasonable. To look for the safety, not the efficacy, just the safety. So those people, they want to say, we know it's very effective, but is there any issues about the blood pressure by combining them? Is there any issue by for the potassium by combining of them, or if there is any acute kidney injury by combining all of these things. They found in that study that adding, SGL2 or starting the finerenone and SGL2 in the same time with this kind of patient who have moderate CKD and macro to proteinuric level, it's very, very safe and giving the long-term benefits with no effect on the blood pressures, which is the main concern. There is no effect in dropping the blood pressures. The good things in that study, very minimal and very less hyperkalemia. And I know, adding SGL2 helping to treat the hyperkalemia might be induced by finerenone. So, if you can see the number of the hyperkalemia here, or the admission due to hyperkalemia, dropped from 1.6 in the fidelity to almost 0.7 in the confidence trial. So I think it's very, 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 for me, I'll be in favor of starting whatever, like SGL2 first or finerenone first, but it should be in RAS blockade area to that one. Next. Okay, so American Diabetes Association and CODICO guidelines, which is the leading guidelines and initiatives improving the renal outcome, in 2022, they just recommend this 3 sentence, very, very important. And they mention in a patient with CKD who have a high risk for cardiovascular or chronic kidney disease progressions, or unable to use SGL2, mineralocorticoid should be used. This is evidence, and it's 1A. For patients with type 2 diabetes, with a maximum tolerated ACE inhibitor or ARBs, finerenone should be used to improve the outcome of the kidney disease, regardless SGL2. And we should keep eye on the potassium level. They suggest as well, in American Diabetic Association, we suggest nonsteroidal MRA antagonist with proven kidney or cardiovascular benefit for type 2 diabetes and GFR more than 25. We should keep eye on the serum and albuminuria, very, very landmarking here. So we should have proteinuria to have the benefit of the finerenone. Okay, next. So just remember, I want to add to finish by this one. Just remember the rule of 5. Use finerenone and CKD with type 2 diabetes of potassium at most of 5 and estimated GFR 25. Don't stop till potassium reach up to 5.5. Expect the 5th reductions, like 25 reductions in dialysis risk, or more than 5th reductions in cardiovascular failure, on top of what we get, over the last 17 years from ACE inhibitor and ARBs. Key is to start when estimated GFR preserved to mitigate, the risk of hyperkalemia. So start as 60 down to 45. Don't wait till you have more advanced CKD. This is well said by Rajiv Agrawal, and everyone knows him. He's a prof, and he's professor at Indiana University. He's a principal investigator in those 3 trials, and he's very active principal in confidence trial. I know there is one slide about Dr. Khalid mentioned about the hyperkalemia. Hyperkalemia, I think we should use it when potassium less than 4.8. The dose adjusted by the GFR, as Dr. Nora said, we should read the potassium after 1 month and the potassium after 4 months. If it is more than 5.5, we decrease it from 20 to 10. If it is keep higher, we hold. If it is improved, we just continue, and we can titrate up the dose. There is a written protocol for the hyperkalemia, and this will be in the leaflet of the medications and in the hands for all the end user or the prescribers. So as a conclusion, annual screening is very important. Screen for your patient. Don't wait for your patient. A lot of your patients very suitable for this drug lagging behind. They are lost in the system. So screen them, bring them to the clinic. Before MRA initiations, patients should be in RAS system. This is, full agreement and ethical agreement. Diabetic kidney disease patient should be in good glycemic control, good metabolic control, good hemodynamic control, and standard of care earlier by 60 GFR and late 300 to less than 5 gram proteinuria is a feature for the best candidate for MRAs. So diabetic kidney disease patient with controlled systemic disease, uncontrolled like cancer, malignancies, cardiovascular, liver should be excluded. An MRI initiation decision always is irrespective to the availability of SGO2. So it's very independent drugs in diabetic kidney disease patients. So with this, thank you for your attention, and back to you, Dr. Nora.
Thank you, Dr. Sultan, for this really interesting and informative presentation. Our next speaker is Dr. Hussein Al-Bdawi, who's a consultant of internal medicine, endocrinology, and metabolism. He's also the chairman of metabolic unit at my clinic in a medical center in Jeddah. Welcome, Dr. Hussein.
And good afternoon, my dear colleagues. Of course, my task now is to try to just take you through the application of the knowledge that we have acquired over the past few hours, starting from our introduction about diabetes and approaching CKD, and understanding the pharmacology of finerenone, followed by the understanding of the side effects and the benefits of finerenone, and looking into how we can help our patients when we start seeing them starting from today or tomorrow in our clinics, to offer them better tools to make them live longer, happier, and healthier lives. So again, the title of the talk is Putting Everything Together. I will just give you a case that actually we have seen last month. The name is not real, but the rest remains as true as it is in his file. So this is Mr. Samir. He's a 46-year-old individual with type 2 diabetes, which was diagnosed 6 years ago. He has a CKD, which was discovered upon diagnosis. And at the time, his estimated GFR was 55 mils per minute. Now, he was initially treated with diet, exercise, followed by metformin. And then, because we know that diabetes is a chronic disease and it is a progressive disease, so that is why we need our patients to follow up regularly. With 2-3 years into his disease, his A1C started to increase, so he was placed on dulaglutide, as he has overweight as well. As you can see, his BMI is currently 28. And looking into his laboratory investigations, you can see that his hemoglobin A1C is 7.5. And that is relatively suboptimal for someone his age. His office blood pressure was 138/80, and his estimated GFR currently is 42. As we said, CKD is also progressive, so the decline over the past 6 years was from 55 to 42. His urine albumin creatinine ratio at baseline was 410. His serum potassium is 4.2. He does not have any signs of heart failure. He is optimized on his anti-dyslipidemic medications, with atorvastatin 10 reaching LDL goal below 70, which is 50 milligrams per deciliter. So these are his current medications. He was, because of his proteinuria, placed on an angiotensin receptor blocker, irbesartan 150, that was later maximized to the maximum dose which he tolerated, which is 300. And this is a very important key point that Dr. Sultan just noted, that because the trials mandated that when we added finerenone, patients were taking the maximum tolerated dose, that you must ensure that in a patient with type 2 diabetes, CKD, and proteinuria, you optimize to the highest tolerated RASI inhibitor. So in this person, I'm highlighting where he was. His eGFR is 42, remains the same, but from last month to this month, his urine albumin creatinine ratio was 410, and suddenly you find that it jumped up to 1 gram or 1.3 grams. So that is quite an increase. And his A1C is the same from the previous 3 months, so it is still suboptimally controlled. Now, the question is, how should we approach a patient like this? So is there means of optimizing therapy, preventing any progression of disease? So we'll start off by saying, well, from a CKD perspective, we have learned that addressing the hemodynamic stability with the ACE and ARBs will reduce the risk of progression, and addressing the metabolic parameter, which is improving glycemic control. So one of the main reasons for worsening albuminuria is worsening hyperglycemia. And both together, you can see that we have seen this slide earlier, that when we optimize the ARBs, or as seen by the Renal study, we can reduce the residual risk of CKD progression, as well as adding an SGLT2 inhibitor, the DAPA-CKD, can reduce the risk of progression. So this patient clearly may benefit from the second element of SGLT2 inhibitor, as we have heard from the last lecture with Dr. Sultan. And if we want to place this patient on the heat map, and I advise all of you to get a print or a little card so that the next time you see a CKD patient, you can actually show them where they fall on the line. And this is what we do. In order to help patients' awareness and engage them in the decision-making, we tell them, look, Mr. Samir, you are currently on this part of the heat map, which is this red block, which falls in the stage 3B and with severely increased albuminuria. Being in the red zone means that you have a higher risk of cardiovascular mortality, and we want to prevent that risk from happening. So that helps, that kind of discussion will help the patient appreciate the degree of danger he is in. So going back to Mr. Samir, he agreed to taking an SGLT2 inhibitor, and in his case, the current recommended dose for empagliflozin, which was available in the center, was 10 milligrams. Now, I will also make a small comment. Dr. Sultan just told us that, is there any difference if we start it before or after another agent? Well, like we said, because we don't have finerenone now, this is at least the minimum you can do to prevent the progression of kidney disease. So we started him on the empagliflozin. 3 months later, he comes to us with a much improved hemoglobin A1C. So he was at 7.4, now he is at 6.8. So now we can say he is well controlled based on the guidelines. The second thing we have noticed, that after being at 1,300 milligrams per gram of albuminuria, he dropped down to 700. Now, he is on empagliflozin, dulaglutide, metformin to control his blood sugar. He's on irbesartan maximum dose. Now, at this point, with adequate glycemic control, adequate blood pressure control, are you happy with his situation? Or can we help him prevent progression of kidney disease? So this is where our thought process will take place in the next few months, with the availability of the third component of progressing or preventing a progression of kidney disease, which is offering the mineralocorticoid receptor blockers. Now, I'll remind you, as we've seen with Dr. Sultan, the finerenone in the studies have reduced the urine albumin creatinine ratio compared to placebo by almost 30-40%. And that was maintained throughout the trial. So that means that there is great benefit from adding this. Now, our patient here had persistent albuminuria. He was at 700 after adding the SGLT2 inhibitor, but the right answer is to try to address this with the mineralocorticoid receptor blocker. And here's where, when we added finerenone, within 1 month, his albumin creatinine ratio actually improved to 400. Now, the small thing that we have seen is that his potassium level within a month increased slightly from 4.2 to 4.4, not significant. The GFR was maintained, the blood pressure was the same, and that was seen in the trials that we have seen earlier today, where there was no increase in blood pressure, there was no decrease in blood pressure, there was no increase in hemoglobin A1C, so dysglycemia was not seen with this medication, nor was there any hypoglycemia. So this tells us that this medication works independent of the hemodynamic or the metabolic pillars of CKD progression. And it works, as we've seen, in the inflammatory arm. So as of now, we have a patient who's 46, type 2 diabetic with CKD, at a much better state. His A1C is 6.8. His urine albumin creatinine ratio came down nicely by almost 50%. He is at 400. With progression of the 10 milligram dose of finerenone, his serum potassium is at 4.6. There was no hyperkalemia status found. And here's where we ask, well, all right, we're stable now. Shall we do something else? And here's where we can say, well, someone will ask, can we increase the dose of finerenone to 20? Well, we have learned today that actually 10 is the maximum dose when you are at the GFR that is below 60. And therefore, we would just maintain the 10 milligram at this point. Now, if this was someone with normal GFR or GFR that was above 60 with albuminuria, then potentially we can start with 10, ensure no hyperkalemia on repeat blood testings, and then we can increase to 20. Now, I want to also just remind everyone that sometimes some of the basics we should remind our patients, especially with chronic kidney disease, which is a low potassium diet. Many patients, you'll be surprised when you start to see a climbing potassium. Before blaming the drugs, ask the patient, have you been taking bananas, tomatoes, dates? Because some of these small interventions can actually make a difference. I hope in this simple case, which was relatively straightforward, we have learned a lot of how we can help benefit our chronic disease patients, especially DKD or diabetic kidney disease with albuminuria in the coming few months. So I will just conclude by saying I have personally learned today that the burden of cardiovascular disease is very high in patients with CKD and type 2 diabetes, despite having many medications, and that all the guidelines we have seen throughout the day, not only from the renal KDIGO guidelines, but also the American Diabetes Association, as well as the European Heart Association and the American Cardiology or College of Cardiology, all of them talk about addressing kidney disease in diabetics. And we are blessed now to have finerenone, which is a selective nonsteroidal MRA that has multiple benefits, one of which is reducing the risk of CKD progression by 23%, and the cardiovascular morbidity and mortality by 14% compared to placebo, which is, as we've seen, the largest trial program for patients with CKD and type 2 diabetes up to date. I wish you a blessed rest of the day and look forward to the discussion with all of our colleagues.
Thank you, Dr. Hussein. Really, with your presentation, the picture is now, I think, clear for the audience because it's a practical case of what we said from the morning session. And this patient, Samir, is really like the patient we see all in nephrology department and endocrine. Also, it's similar to our relative because, you know, diabetes is a burden disease in Saudi Arabia. With this, I would like all the speakers to come for the discussion. So the first question from Fatin, she asked, does non-steroidal MRA has unfavorable effect on GFR? I think this question's for Dr. Khalid, if he's available.
The question, Dr. Nora, does it what?
does MRA has unfavorable effect on EGFR? I think you can answer, Dr. Sultan, this question.
Yes. It's it's fine. Me or Dr. Sultan here, Dr. Sultan. You can go ahead, Dr. Sultan. It's fine.
It's one of the safety, parameters there, Dr. Khalid.
Yes, actually, for the GFR, as I showed in this slide, there is just a minor drop in the GFR by 3 ml per minute. So it's not significant and it's assumed to be physiological. So it means after you stop the drug, it might go back to the baseline. And if you look at the end of the study, overall there was a long-term preservation of the GFR and the intervention, the comparison to the placebo group.
Yes, thank you, Dr. Khalid. I'm sorry because I'm not seeing the picture. I thought you are not available. Okay, the next questions. Can we... okay, is there any specific GFR before the starting Firinon or when we stop Firinon? For, I think, Dr. Sultan.
Yeah, we mentioned it like the early is the better, and the more degree of proteinuria is the better. This is like for which kind of diabetic kidney disease. So 60 we are favorable GFR. However, because of the majority reaching our clinic is maybe like from 30 to 45. So, however, it's good to start them on that. Just in a line to the question you ask, for the GFR, as Dr. Khalid said, the drop in the GFR is very minimal, and that's why you are giving 4 weeks of GFR stability on the maximum dose of AC inhibitors. However, I think like what we are doing with SGL2, we could encourage the patient to cut half, of the RAS tablets, RAS system tablets, and to drink more water, or fluid in the first, let's say, 7 days, just to avoid, like, let's say, however, the risk is very minimum, but just like to make precautions in those. Still, we have to build up our experience with this medications.
Sultan, also the last questions to Dr. Hussein is the same in GFR, but they said in the areas with no facilities to measure GFR, is there anything to monitor the patient for?
Okay, so very good question. I want to reassure my colleagues who don't have a reported GFR that the GFR is actually a formula that reveals an estimate of the glomerular filtration rate. So it's not an actual measurable number. So if you have creatinine or serum creatinine, and you have a patient's body weight in front of you, technically you have everything you need. And if you go online, there are many resources of calculating the estimated GFR based on 3 different formulas. The simplest way of doing it is going just to kidney.org or going to the KDIGO guidelines. It'll inform you how to do it. So you just plug in the numbers and it will translate it to you. And that's how, in small facilities, we tell them at least the creatinine, you can achieve it by that thing.
Yes, thank you,
And
Dr. Hussein.
I want to just also, if I may, having urine albumin creatinine ratios or spot urine may sometimes be difficult, but at least for screening purposes, urine dipstick, if you can find protein, then you can advise the patient to go to a facility which has further testing so you can get a quantitative amount. But that's the minimum we can do.
Yeah, that's right, Dr. Hussein. By that, I will conclude with thanking you all, Dr. Sultan, Dr. Hussein.
So, just for this is very important what Dr. Hussein mentioned, and we never do biopsy for diabetic kidney disease, or we did it for some reason and we found that diabetic kidney disease. But I think we could get benefit from our, let's say, unnecessary biopsy. I found a lot of patient who has more EFTA, like tubular atrophy and interstitial nephritis in a biopsy with diabetic kidney disease. I think this is the best model, to know what is the best patient. Because EFTA from 35 to 40 in a biopsy, I'm not recommending biopsy, but if we have it for any other reason and end up with diabetic kidney disease with fibrosis, this is one of the excellent tools to put our patient on it. And I think in American Society of Nephrology, there is translations, presentations talking about the future of diabetic kidney disease pathology in determining the patient and observing the prognosis.
Yeah, that's very interesting, Dr. Sultan, and really it's a growing area. And we are happy to see some medications that help our patient to decrease the progression to kidney disease and the need of dialysis. Any other comment from our distinguished speaker? Okay.
Thank you.
Well, thank you so much. Very interesting. I think, you can conclude, Dr. Nora.
Okay, we will conclude our webinar today with all the speakers, Dr. Sultan, Dr. Hussein, and Dr. Khalid. Thank you all. And thank you to the organizing committee.
Yeah, thank you, Dr. Nora. I think now we will close up with breakout take-home messages from the presentations. I'm really very proud, as organizing members with my colleague to have this excellent, talk, excellent knowledge, excellent informations. And I believe, this is the way of having, the preparations or increasing the awareness of the medications. Bring all the specialties together. Let's talk and let's come with conclusion and consensus, other than like every literature or every specialties giving their own favorable way. I think all together, because this is a multidisciplinary approach, it's very, very leading chronic diseases need to be treated, and there's a lot of demands, from mortality and morbidity to have a very excellent approach to catch those patients and put them on the standard of care. I know in the different sessions there's a lot of information. I try over this 2 minutes to put it all together. So the next slide. So we know diabetic kidney disease is the most common cause of end-stage kidney disease in the United States, in Saudi Arabia, and the global. And for years we are just doing like some treatment for the risk factors, controlling the blood glucose, blood pressures, dyslipidemia, using RAS system to slow the progressions. And for years, AC inhibitor and ARBs become the sole therapeutic options over for diabetic kidney disease and the cornerstone of treating those patients. But we are now, unfortunately, able to have another medications and another agents. Next. So SGLT2, it's coming from like 2011 to 2015 to be one of the leading and equivocal protective benefit equal to RAS system and AC inhibitor and ARBs. GLP-1 and the obesity treatment now it's coming up to be a cornerstone as oral agent for treating diabetic kidney disease, and it now it's going up in the top of the list for the guidelines lines. Mineralocorticoid, especially phenylalanine, is very welcome additions to the growing evidence, and we get closer to a guideline directed the medical therapy for the diabetic kidney disease, including this agent. Next. From pharmacological perspective, Dr. Nora mentioned mechanism involved in pathogenesis type 2 diabetes and CKD, including metabolic, hemodynamic, inflammation, and fibrosis. MRA antagonism can have a benefit on diabetic kidney disease and other diabetes complications. It had favorable pharmacokinetic and pharmacodynamic properties. Potent drug interactions need cautions, especially with grapefruit juice, and assignment of the major and minor subtract status based on the clinical relevant drugs interactions potent to the cytochromes, very minor, and the cytochrome 3A4 is a major. Finerenone has a fewer adverse effect compared to the non-selective steroidal MRA, iloperidone, spironolactone, but the potassium level should be monitored and the dose should be adjusted accordingly. Next. So from the safety profile and the efficacy, in patients with CKD type 2 diabetes, treatment with MRI resulted in lowering the risk of progressions cardiovascular compared to the placebo. Among patients with type 2 diabetes stage 2 to 4, moderate level of proteinuria, or stage 1 to 2 with heavy proteinuria, MRA has a huge role in improving the cardiovascular outcome as compared to the placebo. We learn from Fidelity, which is the individual level analysis and pooled analysis data from the Fidelio renal studies and Figaro cardiovascular studies. There are reductions in both cardiovascular and kidney failure and improving the outcome of both with the MRAs. Next. 40% of the patients included in the studies have excellent GFR more than 60. This is increasing our demand and desire and interest to screen the patients in the primary care sectors, looking for such patients with heavy proteinuria and starting them in this treatment to optimize the cardiovascular renal risk reductions. Next. Dr. Khalid gave an excellent presentation about the safety. So finerenone have a comparable safety profile to placebo. The risk of hyperkalemia is minimum and manageable. And finerenone has MRA, but it has no significance in the blood pressures. And Dr. Khalid answered excellently why these features, because of the selectivity and the gene expressions. The drop in the GFR is very minimum, and personally, I consider it one of the nature cause of the disease, very comparable to the general populations. And the overall preservation of the GFR in the long term is very significant in this drug. So it's very safe. Next. So what is the best time and what is the best candidate on MRA? I know the screening will tell us which is the good patient, and it's very crucial. Before starting that one, every patient should be RAS system for 1 to 4 months. Diabetic kidney disease should have a good control of glycemia, metabolic, and hemodynamic. So good hemoglobin A1C, good level of GFR, and good controlled blood pressures. So the early CKD and the more advanced albuminuria, it are the features of the best candidate for MRA from diabetic kidney disease patient. Uncontrolled diseases, whatever the organs should be excluded from any initiations and contraindication to initiate the MRAs or finerenone. Finerenone not related to say SGL2 as initiation, so it's irrespective to that one, and very safe if we combine it all together. Next. So fortunately, we are living now in an era where we are able to offer different options to diabetic kidney disease. Personally, I believe over the 17 years back, 2 decades, we just give the only available measures. Now we have a lot and bunch of modalities can treat patient and can improve the cardiovascular complication and improving the survival. I think this expanding in therapeutic options has inherent in a new era of diabetic kidney disease, enabling and cardiovascular, kidney, and survival benefits. And this is, I think, the bottom line here in this day. I know it's a very huge day, and I think the beauty, I learn a lot from the presentations, and I feel very, very confident now to deal with diabetic kidney disease in face of finerenone. And I think this is comfortable because I learned from my colleagues, from the other specialties about the safety, efficacy, pharmacodynamic, pharmacokinetics. And with this, I can take like the last comment from my great colleague who helped us in building the program and organizing this event. Dr. Khalid, any comment?
الله يعطيك العافية دكتور سلطان وجميع الزملاء. It was a really great event. I think today we discussed a new say therapy that will help to reduce the burden of the disease in our community, which for a prevalent disease. And I hope together with this multidisciplinary approach, we'll be able to support and help our patient, and inshallah we'll reach this goal together.
Thank you, Dr. Khalid. Dr. Noura?
Yes, Dr. Sultan, really it's very informative and interesting topic to us because as mentioned in the presentation before, we are stuck if we do all to the patient, if they give them the antidiabetic medication, the RAS, and then what's next? We will just wait for them to progress to end-stage renal disease. But now there is a hope with these medications, and we hope it will be available in the soon future to our patients.
Thank you, Dr. Noura. Dr. Hussein?
I want to start by thanking everyone who stayed online with us this whole morning. And specifically, I want to thank you, Dr. Sultan, and the organizing committee, as well as those behind the scenes for supporting this excellent program. And I want to say that, as Dr. Noura just mentioned, there is a light of hope, but there is also a lot of positivity coming out in the next few months, because in the past, whenever we started just to say the kidney is starting to decline in function, the patient leaves the clinic with some negative feelings. But now we can actually boost that with a positive feeling when we tell them that we have a new tool that inshallah will bring more health to all of us, inshallah. So thank you so much.
Thank you, Dr. Hussein. I really special thanks to the Multaqa al-Khubara. Very excellent experience. I think today with this technology and using remote microphone, full screen, different zooming features, very excellent experience. Thank you for the organizing committee. Thank you, Bayer, for the generous sponsorship to make this program up. And I know this is just the beginning. We have a long journey all together. Inshallah, we will have in 6 months and 12 months what we call a data share and patient experience webinar. Then after that, we will encourage the research in that area. Then we'll have maybe research day about MRIs. However, a lot of ideas. It will help the audience, and at the end, it will help the patient, which is the most important for all of us. Thank you. Have a great afternoon and try to enjoy the remaining of the days. I know it's raining here in Riyadh, and it will be fantastic to have some activities. Thank you. مع السلامة. الله يحفظكم جميعا.
طيب دكتور سلطان إذا تسمح لي دكتور سلطان
شكرا لكم. مع السلامة.
في أمان الله.
أيوة يبدو كان الصوت ما يقدر يوصل عندهم ها